Welcome to AETCM, the Emergency Medicine channel. Today we are going to discuss case scenario regarding ACLS management. So this is Dr. Jarin. He will be the team leader for today and I will be giving the instruction for the same. So Jarin, we have a 28-year-old male who is brought to the ER by family after being found drowsy in the bedside, and for the same we were called for the same, and the paramedics reached there and they reported that the patient was having progressive bradycardia along with hypotension while he was being transported towards the hospital, and single dose of atropine was also administered during the transport without any sustained improvement. So this is the case. You can brief your team regarding the same while the patient arrives to the ER.
So I am Dr. Jarin from our department. Today I am the team leader of today's case. Also, we are getting a message from EMS like one patient came with a history of drowsiness with progressive bradycardia and hypotension. So in view of instability, they given injection atropine 1 dose, but there is no any improvement in the condition. So within 5 to 10 minutes, we will get that case. So we get ready for the management of that case. So Nandini, you are okay with for the airway? You are okay with managing the airway? Yes. Okay. Akash, are you okay with managing with defibrillator and monitoring? Then Milu, are you okay with managing with compressions? Okay. Are you okay with managing with IV fluids and drugs? And you are okay with giving a timer? Okay. So
you have assigned, you are the team leader and you have assigned the roles, right? So right now the patient is being brought to the ER. So on arrival, he is drowsy with shallow breathing.
Okay. So first of all, we check the patient is responding. Can you check?
Are you okay?
Patient is responding but drowsy but arousable with shallow breathing.
Okay, coming to airway, any secretions?
Little secretions are being noted, and some gurgling of sound is also there.
Okay. So first of all, we give a suction to remove the secretions. Suction done.
Still, the patient is persisting to have some audible airway sound is coming out.
Okay, can you give the patient head tilt and chin lift?
Yeah, little improvement is noted, but not completely okay.
Any patient had any history of trauma or any base of skull or fracture, anything?
Currently, we don't have the history yet regarding that same. Patient is still being brought to ER only. We have to take the further detailed history. You can further go ahead with your primary survey.
Okay. So coming to breathing part, respiratory rate is?
So patient on coming to ER itself, patient was having a desaturation and he was being on O2 support with 88% on 6 liter O2 via simple face mask. Respiratory rate was shallow, so the patient was having a rate of 6 per minute.
6 respiratory saturation is 18 5 liter O2.
Yeah, 6 liter O2.
We can start with patient in 6 breath per minute. So we can start with rescue breath with bag and mask ventilation with 10 breath per minute. Okay. Any added sounds like wheeze, creps in auscultation of chest?
Little creps were noted during auscultation. Other than that, nothing much significant.
Okay. After giving bag and mask ventilation, any improvement of saturation?
Saturation is improving little by little. Currently, the saturation is 90%.
90%. In coming to circulation.
Okay. Circulation. So patient is still having desaturation, and you have you are directly going with the circulation part, right? Okay. So patient's heart rate is 28 per minute, and his we can connect to the monitor and we will see the further things.
We can connect to the monitor.
For the same, BP is 60 by 30 mmHg.
60 to 30 and 28 is the heart rate. We can initially connect to the monitor the patient, and we can start put on 2 large IV bore cannula, collect the blood samples, routine investigations, and start with IV fluids bolus 20 ml per kg. We can start with IV fluid bolus.
IV fluids given. Exam is collected.
So initially, patient was given 1 mg atropine by our AMS team, but patient is not responding. Still also patient with bradycardia with hypertension which is unstable. So we can again give 1 mg atropine. Can you give 1 mg atropine?
1 mg atropine given.
1 mg atropine. How do you say that a patient is unstable or stable? What are the signs of instability?
Signs of instability: patient with bradycardia with hypertension with alternate mental status, features of shock, features of cardiac failure, feature hypertension, and chest discomfort.
Okay,
5
these are the
features.
signs of instability. And
Instability.
in this case, what will be your management?
In this case, we can initially start with atropine 1 mg. We can wait for 3 to 5 minutes. If it is not responding, we can repeat up to 3 mg. Then also patient is not responding, we can start with dopamine infusion, which is 5 to 20 microgram per kg per minute infusion we can start. And again, patient is not responding, we can give epinephrine or we can go on with transcutaneous spacing.
Okay. So currently 3 minutes has been over. What will you do? 3 minutes
After second dose, we can give again third dose of atropine 1 mg. We can give.
So you can give second dose of atropine. No? First dose you have given right now.
From EMS will give one.
So this will be the third dose.
Third dose.
1 mg atropine given.
In the meanwhile, we can assess the breathing part. Any saturation is improving.
Saturation is not at all improving with the mask actually, bag and
Okay,
mask.
so we can move on with considering threatened airway. We can move on with maintaining the airway with advanced airway because patient have history of desaturation, shallow breathing, and cups. So suspecting aspiration. So in with threatened abortion, we can go on with at advanced airway. Can you intubate the patient? Before going to intubation, we can use 8-size tube with drugs like rocuronium and patient in hypertension. So we can give it ketamine.
Okay.
Atropine ketamine given, sir.
You can specify the dose for the same rocuronium. and
Rocuronium.
ketamine. You have to maintain the closed loop communication.
So again, going to intubated. Auscultation part, bilateral equal air entry connected to the bag and mask. We can start with 1 breath per 6 seconds. That is 10 breath per minute. And auscultation is both sides equal. Can you?
Still after giving the atropine also patient is not having an improvement in the heart rate.
Bradycardia with hypo- Again, then we can start on patient with dopamine infusion with 5 to 20 microgram per kg per minute infusion we can start. Can you start?
Infusion started, dopamine 5 to 5
Okay. So by that time, so the bystanders told that the patient was found lying beside near the bedside patient. Before the patient, there was some like empty strips of some medicines were noted. So they are unaware of the medicines currently, but they will be getting to. We will be getting to know the medicines soon.
Okay.
So we have started with the dopamine infusion has been started. No, still there is no elevation improvement in the heart rate.
Then we can move on with transcutaneous spacing.
Okay. Monitoring.
Adult mode.
Suddenly the patient became unresponsive. There is no pulse. You can check for the further.
Can you check for the central pulse?
The system is the monitor is not showing any normal. There was only a white complex rhythm.
No pulse.
Checking.
breathing, no pulse and no breathing.
No breathing. Okay.
Start CPR.
Starting CPR.
So what do you assess? And so pulse is not there. Some rhythm is there. What
Okay.
do you call it actually?
Basically, pulse is not there. Rhythm is a pulseless electrical activity. We can give adrenaline, 1 mg adrenaline, 1:2000 dilution. We can start with 1 mg adrenaline, which is repeat every 4th minute. See, continue CPR. We can reassess the patient every 2 minutes.
1 ml 1 mg adrenaline 1000 dilution given, sir.
Okay.
So you can discuss about the 5H and 5T
Five reversible
regarding the
causes.
same.
So basically, any reversible causes of cardiac arrest like 5H and 5T. In 5H, hypovolemia, hypoxia, hypokalemia, and hyperkalemia. increase H plus, that is acidosis and hypothermia. And anything in this patient, anything is there, sir?
So in this condition, we have found out that
Hypovolemia?
patient is having there was no from the history as such we were not able to assess the regarding hypoxia and hypovolemia, maybe because the patient was having
Hypertension is there.
hypotension was there. Other than that, we haven't checked for any other parameters. No, if we check only, we will be getting to know about further parameters. You can discuss about the
5 T's,
5 T's also.
coronary thrombosis, pulmonary thrombosis, tension pneumothorax, cardiac tamponade, and toxins. Any reversible causes in T's, irreversible causes?
Yeah, as such we have known to know that patient was having some empty strips beside him. So by the time right now we know these are the medicines that he took. So there was empty strips of diltiazem, propranolol, and amitriptyline.
That is beta blocker and calcium channel blocker and TCA, tricyclic antidepressants.
Yeah, tricyclic antidepressants.
Okay, so basically patient will take beta blockers, calcium channel blockers, persistent hypertension with bradycardia. Again reassess the patient, check for central pulse, rhythm.
There is no pulse.
No pulse. Start continuous CPR, give adrenaline second dose. For every 4th minute, give adrenaline. So in this patient, we suspected beta blocker and calcium blocker, persistent hypertension. Already we given atropine and dopamine and transcutaneous spacing. Then the next management is give injection glucagon. Can you take injection glucagon doses? Initially, we can give bolus dose, that is 2 to 10 milligram we can give. Then followed by we can start on infusion.
Injection calcium glucose to
To MG1.
What? Which is the drug that you have given right now?
Glucagon.
Glucagon. So you have given glucagon, right? Okay.
Wait for 15 minutes. We can reassess the patient, like hypertension or bradycardia is improving. If after also 15 minutes, if the hypertension or bradycardia was not improving, again repeat the same dose of glucagon.
So Jarin, what is the need for giving glucagon?
In basically in beta blocker toxicity, beta blocker is acted by the beta GS stimulating receptor. By that receptor, we will increase the adenyl cyclase, then causes increases cyclic AMP. That is the normal beta adrenergic receptor activity. So beta receptor is blocked by the beta blocker drugs. So there is decrease the amount of cyclic AMP, which is at last second messenger producing the cyclic AMP. So glucagon act independently on other receptor and it will increase cyclic AMP.
Okay.
15 seconds to 2
So it will increase the myocardial contractility.
So 2 minutes as nearly reaching 2 minutes. What any other drugs that you can give?
Other than we can start with high dose insulin euglycemic therapy.
Okay.
So can you start?
2 minutes complete.
Okay. You can give adrenaline and reassess the patient also.
No change in the rhythm. You are giving other drugs. What are the drugs?
High dose insulin euglycemic therapy. We can start.
Okay.
Insulin, that is 1 unit per kg. 1 unit per kg bolus we can start. That is patient weight is around 60 kg. So around 60 kg bolus we can give. Then followed by 1 unit per kg per hour infusion we can start. So while starting insulin infusion, we check the GR-base before that. So make the patient GR-base between 100 and 200. If it is less than 100 or less than 200, we start with 10% dextrose, 200 ml per hour along with insulin infusion, and also check the serum potassium. Then if potassium less than 2.5, we can correct it with KCL and make the potassium between 2.5 to 3.2.
So here you will need for checking the glucose and potassium. We need an ABG.
We need an ABG for this patient.
So better to get an ABG also.
ABG taken.
Okay.
Is they are being checked.
Okay. So for the same ABG result is like pH is 7.15 with bicarbonate of 15, lactate of 12 with sodium of 138, potassium of 3.2 and the glucose level is 70 milligram per deciliter.
glucose is 70. So anyway, we'll start with initially in 70s. Then we can give a bolus of 50% dextrose, 50 ml we can bolus if it is available. Otherwise, we can start with 25% dextrose. We can start. Then make the GR base between 100 to 200, and potassium it's okay, it is 3.2, and ABG showing severe metabolic acidosis with a bicarb of 15. Then also patient monitor showing wide QRS.
Metabolic acidosis,
Metabolic acidosis, bicarb. Okay. Can you reassess the patient?
Anything else you wanna give? You have given glucose, glucagon, and insulin.
Insulin. Pulse is there?
Not pulse.
No pulse. Continuous CPR. So wide QRS with a bicarbonate of 16, there is an indication to give sodium bicarbonate infusion in beta block toxicity and TCA toxicity. So 150 milli, take a sodium bicarbonate in 150 milli equivalent. Infusion we can start 150 milli equivalent. So they dilute it in 1 liter dextrose and start with 2 to 5 ml per hour.
So which are the indications that you give sodium bicarbonate?
Sodium bicarbonate infusion indication with ECG changes like wide QRS, ventricular dysrhythmia, refractory hypotension like this patient, then other than terminal R wave deviation in AVR.
Okay. Anything else you want to give?
Other than that, we can give calcium also, calcium gluconate we can give. Calcium gluconate we can take, that is 10%, 10 ml calcium gluconate. We can take 0.6 ml per kg. That we can give over 10 to 15 minutes. That is around 60 kg, around 30 ml around over 15 minutes. Followed by, we can start with infusion of calcium gluconate of 0.6 to 1.5 ml of 10% per kg per hour. That is around 30 ml bolus given, followed by 30 ml per hour bolus infusion we can start.
Okay. Other than calcium gluconate, any other calcium formulas we can give?
That is calcium chloride is not available here. So it is 3 times more concentration content is than calcium gluconate.
Okay. So 2 minutes is been over. Still it is showing the rhythm. You can check for the pulse. Okay, no pulse.
Pulse was not there, continue CPR.
Anything else to try?
If we given sodium bicarb, calcium, insulin, glucagon, then patient is not getting to still on cardiac arrest, we can start with ECMO.
ECMO we can try. And any other drug that we can give in this condition also? We can also try.
Phosphodiesterase inhibitors we can give.
Okay. Lipid emulsion
therapy we can give. It will cause us. Basically, it is better in drugs which have lipophilic drugs. So it will. The theory is lipid sink theory. So lipophilic drugs will attach to the lipid emulsion, and we can remove it. So it is a lipid sink theory.
Okay. So we can administer that also. No? Okay. Continue with the CPR. So, what are the? Can you explain briefly what are the drugs that we can give in cases of a condition with TCA or CCB poisoning?
Beta blocker, TCA toxicity. We can initially bradycardia hypotension we are managing. Then, if we get to know about the drugs, we can give first line as glucagon. According to Denali, we can give glucagon, and if glucagon is action is by glucagon independent receptor, then you can give high dose insulin. Insulin is given because in stress condition, cardiac activity is mainly dependent on glucose. So to uptake of glucose is done by giving insulin.
Okay.
That's why we are giving high dose insulin in beta blocker toxicity.
15 seconds to 2 minutes.
Then we have calcium gluconate and lipid emulsion therapy. Okay.
Then persisting hypertension we can give on with vasopressors or norepinephrine or adrenergic agonist also we can start.
Okay. So we can check for the pulse. So currently now pulse is present, and this is the rhythm. So
patient achieved ROC with a sinus bradycardia. So
So
post
you can go with the post cardiac arrest
care. Already patient airway is maintained with advanced airway. We keep the saturation between 92 to 98%, and respiratory rate and breath per minute. Then PCO level is 35 to 45. Then coming to BP, systolic BP more than 90 with a MAP is more than 65. Then patient is like is responding or is in comatose state. Sir?
Currently the patient is in comatose state.
So then we can plan with taking a CT brain and an EEG, and also we can manage the target temperature management with keep the temperature between 32 to 36 degrees Celsius and critical care management.
Okay. So patient has achieved ROC, bradycardia is still persisting. We have to further evaluate for the same, right? Okay. So you can debrief the team regarding the same.
So we get a patient, 28-year-old male patient with a history of drug overdose like beta blocker, calcium channel blocker and TCA overdose. And patient came with history of drowsiness with a shallow breathing, with hypotension and bradycardia. So initially we airway patient had a snoring and sound is there. So we maintain the airway by giving at lift and chin lift, but still it is persisting and patient is shallow breathing. We initially started bag and mask ventilation, but there is features of aspiration. In view of threatened abortion, we intubated the patient. Then we give on with drugs like atropine and dopamine, still also bradycardia and hypertension is persisting. We move on with definitive management of the beta blocker and TCA blocker. Then followed by patient goes into cardiac arrest. So patient in with a monitor showing PEA, that's why you give adrenaline every 4th minute and continue to CPR. After starting with definitive management, patient achieved ROC after 4 cycles of CPR. Then patient revived within after 4 cycles CPR. We post cardiac arrest management was done.
Okay. Any suggestions to improve the whole thing? Closed loop communication can be improved, and you can say the things very little more loudly also. That will improve the communication skill as well as prognosis of the patient, and CCF also can be improved by maintaining the same thing. What do you mean by CCF?
Compression system.
Just compression fraction. So that if at all possible to maintain a CCF above 80%.
80%.
Okay. Anything else you want to say? Okay. Thank you.